Hey everyone, we're going to further discuss infant neonate assessments. We are going to talk in this recording about the medical history and how important that is, and also some basics of physical assessment. So, in doing some research, I found in 2016 about 7.2% of women who were pregnant smoked. That's something we definitely need to know about the mother when we are doing the perinatal history. So we want to look at maternal history, and we want to ask those top questions. We want to ask the mother, do you have a history of smoking? Because we know that affects the health of the baby, often causes low birth weight, may cause premature delivery. We want to find out, did she have prenatal care? Did she have it often and as recommended? Did she have blood work done, amniocentesis, any type of LS ratio, etc., so that we know exactly what the gestational age of the baby is and what they've been exposed to? What is the age of the mother? The average age of a mom in the United States is about 25 and 8 months old, so almost 26 years old. So you're going to be working with young ladies of all ages, and definitely much younger and some older than that. We know that if they are older than 35 years old, they are a high risk delivery because of advanced age of the mom puts them at more risk for trisomy issues and Down syndrome and some other conditions. So we also want to know, has there been previous pregnancies and related complications? Was the mother diabetic during the pregnancy or before? Was she hypertensive? What is the family history and relative diseases, pregnancy complications, and patterns? We want to know, did mom have any significant drug use, alcohol use? Was she abused in any way that would have put her under a lot of stress or possibly caused damage to the fetus during pregnancy? If she was diabetic, we know that may result in an increased birth weight. I think I shared an 18-pound baby born, I believe it was in a foreign country, I believe it was an Asian country, and the mother was diabetic. So a lot of times when you hear these babies being born at 11, 12, 18 pounds, the mother has been hyperglycemic and suffered some at least gestational diabetes, if not other types of longer chronic diabetes to result in a larger birth weight. So that would be something to deliver a baby that was 18 pounds. So the gestational age of the baby is very important. A term infant is 38 to 42 weeks. So 2 weeks early or 2 weeks late is considered term or normal. Less than 38 weeks, if they're born before the end of the 37th week, we consider that preterm. If they're born later than 42 weeks, we consider that post-term. We know that being born post-term definitely puts them at higher risk for meconium aspiration syndrome. So this information is very important. We want to know what the birth weight of the baby is. We always see that celebrated, the weight of the baby, the length, but it's also very important to the assessment of the baby upon initial entry into the world. So a low birth weight is related to increased risk of complications. We know if the baby should be born around 3,000 grams for a term infant. Minimum survivable age and weight is usually 26 to 28 weeks and around 1,000 grams. So I think I shared with you guys, I adopted a little boy that was born at 27 weeks and weighed right around a pound, and then adopted his sister as well, and she weighed about 2 pounds when she was born about 34 weeks. So they were both preemies. he's had more issues with learning disabilities and things, but we've overcome a lot. He's doing very, very well. So just because these children are born early, they were both exposed to some issues in utero, not the best prenatal care, but as long as they get good care after birth, and we definitely hit every doctor's appointment and dental appointment and everything else, and we had lots of therapists coming into the home once they come home to us, and we were able to thwart some of the side effects of being premature and being exposed to some things that babes shouldn't be exposed to in utero. So it doesn't mean that the baby does not have hope of leading a normal life. They definitely can. They just may need a little extra help for maybe for a little while, or even for their into their adolescent years. But they can definitely become valuable members of society if they have that intervention. So, but we want to look at that when they're first initially born. What is the mom's history? What is the family history? What is the initial appearance and assessment of the baby? What challenges do you see from the very beginning? So once we do the physical assessment, we know we want our pulse to be between 110 and 160. Anything over 170 is considered abnormal, and the child will need some oxygen intervention to relieve whatever stress is causing the heart rate to be increased. We need the respiratory rate to be between 30 and 60 with no apnea. Any apnea over 20 seconds is definitely concerning and may need caffeine citrate and an apnea monitor to alert the staff and then the parents once they're discharged home if there is an apneic event, so the baby can be stimulated and whatever intervention that needs to be done at that time. We know that we need to train these parents on newborn resuscitation so that if an apnea event does occur at home, they know how to initiate CPR as they are calling paramedics and having them transported to the emergency room. We also know that SIDS is more prevalent in white Caucasian males less than 1 year old, but it definitely happens in all genders and in all nationalities. So we need to protect these children from these apneic events and from the risk of SIDS. We need to teach the parents to look for the danger signs like cyanosis, blueness of the fingertips or extremities, around the lips, around the nose. We also need to remind the parents it's never normal for them to have retractions. If they're working harder to breathe, signs of ventilatory distress are intercostal, subcostal, substernal, supraclavicular retractions. You'll want to put that in language they can understand, but you want to teach them that anytime that their child is in respiratory distress, they need to seek medical intervention. Grunting upon exhalation is kind of a natural peep that a baby might do, and it's definitely a sign of ventilatory distress that you need to notice if it occurs while they're in your care, or the parents need to be aware of once they are discharged home. Nasal flaring, never normal, indicates ventilatory distress, definitely a sign that they need intervention. Capillary refill, increased refill times indicates there's problem with cardiac output. So not all cardiac issues are always caught before the baby is discharged. So we definitely need to have the parents to call and inform their pediatrician if they notice any type of change or anything alarming with their baby's appearance. Heart sounds, the murmur is an indication of a likely congenital heart defect. We'll talk more about those on the main page and in the future. The baby needs an echocardiogram ultrasound at that point to investigate further to see if there is any type of congenital heart defect that may need medication or monitoring or surgery or all three. So we definitely want to be aware of who the local providers for apnea monitors are. We'll want the child to have an apnea monitor if there are any witnessed events more than 20 seconds while they're in the hospital after delivery, or at any time. If they've had a sibling that's suffered from SIDS, then they will want to have an apnea monitor for that child's discharge, so the parents can be made aware if there are any episodes. Even if the child has had no witnessed apneic events, but they've had a sibling that suffered SIDS, then that child needs to be sent home with an apnea monitor. So know who your local RTs are that are good educators for the family and that can bring the apnea monitors to the hospital, and then educate the family and the staff on how to use them while they're there. And then once they go home, that RT will follow them home and be in contact to do downloads and reports to the doctor during that first year of life, and also to re-educate any new caregivers, or if the child goes to daycare, the apnea monitor would need to go along with them. Anytime the child is asleep, they need to be on an apnea monitor. If there is caffeine citrate was needed to thwart the apneic episodes, or they've had a sibling pass of SIDS, or any significant apneas over 20 seconds. So any apneic periods less than 20 seconds is somewhat normal for infants, and they may not need a monitor at that point. But over 20 seconds, they definitely do. Parents need to be taught how to respond to alarms, when to call the physician, when to alert the emergency response system, and how to do basic cardiac life support. Okay? Well, thanks for listening. Definitely join our study group and subscribe below to get updates when we have new recordings that are published. Thank you. Have a great day.